As many of you know, we started out with a matrix that many of you are aware of, and it's evolved over time. And I would say even today it's still evolving with little changes that John gave me this morning, but there's always some great idea. So I'm going to just spend a little time on this, and then we're going to get more specific about Chad. But remember that we talked about creating a sustainable health system, not a health care system. And the reason that we thought about that is because I don't think we have one now, so the words really matter. So creating a sustainable health system. And to do that, we talked about having 3 legs to that creation. The 3 legs are population health, so based on populations. Traditionally, people in medicine and most businesses are market-oriented. They think about what kind of market share can we get in pediatrics, for example, to sustain our revenue stream, to sustain our workforce, to do all the kinds of things we like to do. That is not the model we're trying to sustain at Dartmouth-Hitchcock. We're thinking about Lebanon as a community that has certain health needs, not healthcare needs, health needs, that we want to design our system to meet those needs. So in your case, pediatrics, in Cliff's case, radiology, in John's case, surgery, in my case, orthopedics. What do the communities we represent actually have as health needs and health care needs? So you could look at rates of diagnosis per 1,000 or rates of procedures per 1,000 and say, how many people do we need to manage that in the communities we serve? And we want it to be value-based, not volume-based. We're not trying to see how many people we can get in here to do that and how many RVUs you can make. And to get to that last point, we want to do it in new payment models. So we want to move away from fee-for-service and RVUs towards more capitation. So the population of Lebanon has problems with drug abuse, teenage pregnancy, mental illness, and a lot of the things you all see. How do we meet those needs? How do we do them in a valued way that says we're actually producing a good outcome at a reasonable cost that the public would be willing to pay for in a new payment model that we'll call capitation? And then how does Dartmouth-Hitchcock, in this case, actually operationalize that? How do we actually take that commitment to create a sustainable health system under those strategies in an operating model that actually delivers on that promise? So the operating model to deliver on that promise has 4 components. One is the enterprise design and strategy team that I lead, thinking about how do we do this? How do we move this forward? How do we create affiliations? How do we create relationships, partnerships to do that now and 10 years from now? And I have 3 colleagues who actually are responsible for this organization across the system every day. Rob Green, who's not able to be with us, is our population health leader. Rob comes to us from United Healthcare. He ran the data analytics. United Healthcare is the largest private commercial insurer in the United States. Rob worked with over 200 ACOs as part of his work. He really understands this world of population health, and with Cliff is a recent graduate of our Masters of Healthcare Delivery Science between Tuck and TDI. So it was great to recruit Rob to this role. Cliff Belden, who's sitting here, who many of you know, was the chair of our radiology department here, is in charge of our integrated delivery system. That's everything. Manchester, Nashua, the Seacoast, the North Country, all of our clinical operations sit under Cliff Belden's auspices. And finally, Enterprise Support Services, John Berkmeyer, who some of you know, John was at Dartmouth, left for 10 years, got lost for a while, found his way back after being in Michigan for a while, and joined us. And John, and we're fortunate to have John back, is in charge of enterprise services. So let's talk about what that is. So we design a strategy, i.e. our commitment to create a sustainable health system. We have 3 legs to that strategy. What does the population we serve need? Not what do we want to offer and give them. We have a lot of things we do. They might not want it. But what do they really need to stay healthy and or become healthy if they do need our services in the hospital? How do we measure that to be the highest quality, lowest possible cost in our value-based strategy? And then how do we actually do it in new payment models, because fee-for-service is a broken model that's breaking our country and is not sustainable, as you all know. And quite frankly, doesn't fit with the values of Dartmouth-Hitchcock. We're not a place that likes to do a lot of unnecessary stuff. We just want to take care of patients what they really need when they're well informed by their families. And we're going to operationalize that by a strategy and design team I lead, by what the population needs under Rob, what the delivery system has to produce for Rob to deliver that care for that population, and John's going to provide all the infrastructure services that Cliff needs and Rob needs to deliver on that promise. That's John's job. IT, HR, all the things related to workforce, management, as we get into telehealth. And then we said, what are specific goals this organization has to achieve, the organization that's creating the sustainable health system, to do that this year? And we can't have 1,000 of them. Each of you have lots of goals, but what are the organization's goals? We want to have 90 out of 100 on the ACO composite quality measures, meaning we want to be really high quality. Who doesn't want to do that? Hard to do because everybody's getting better faster. So we have to keep up with them. We want to increase the number of people we oversee in what we call at-risk populations. That's why we started a partnership with Harvard Pilgrim to create our own health plan partner, Elevate Health. The more lives we have in a capitated model and we get those dollars up front, we can be more assured of those dollars to manage the populations we're trying to serve, not in a fee-for-service, catch-as-catch-can model. We want to be a safe place. We want to reduce workforce injuries. People get hurt working here, lifting heavy patients, moving things around in supply space. 3.4 per 100 is a little high. We want to get it a little lower, so we want to be a safe place. We want to be in the top 25th percentile of the CDC, hack kind of measures, things like needle sticks, hand washing, ulcers, those kinds of things. We want to be in the tops of the country in that. Top 1/10th percentile of readmission rates. We've been really good at this. UHC, the University Hospital Consortium, compares all the academic medical centers. We want to be in the top 10%. Reduce inpatient diversions. This is a big one. This is Cliff's. Access. How do we get people into our system? If we can't get them in, we can't help them. And there's nothing more detrimental to us than having a colleague in Lebanon call up Dartmouth-Hitchcock for an appointment in your area and say, we'll see you in 6 months. Sorry, wrong answer. We want to see all of our appointments, as many as possible, within 3 days. In fact, we do a remarkable job. We see hundreds of thousands of people within a fairly short time. Of course, we always hear about the ones we don't. But some sections and departments need to do a much better job. Access is a lifeline for patients. It may not always be in the typical model we have now of the ambulatory clinic. As John gets more into telehealth, it'll be different, and that'll be exciting. But access is critical to our success. Satisfaction, top 20% against all academic medical centers in the United States. We need to increase our research funding. I've always said that we're way underfunded for our research, quite frankly, $133 million. I think we ought to be at twice that. We have tremendous potential that we haven't taken advantage of. And we need to reduce our turnover. You know, nursing turnover costs us millions of dollars a year in losing great nurses. We can't afford that. It's just not a good business strategy. On the bottom of this, it says we want a 4% margin. You know, people make a joke, no margin, no mission. The reality is we have a lot of expenses. We gave the highest salary increase in the history of this organization this year, $20 million plus. We did that because you worked hard enough to get us close to that. We haven't hit the 4% yet. We need to get there to invest in your future, our future, and our patients and communities' population's future. And I won't let up on that, so you should argue with me about that, but it'll be hard to convince me otherwise. In philanthropy, we've had the best philanthropic years in the organization's history. We just got, this past board meeting, a gift of over $50 million. Before that, we got a gift of $10 million. So things are changing, all for the positive. And I'm very excited about the organization. And at the bottom of this, it says research and education, because that's why we're here. We're a great organization, and education is an underlying principle of the reasons we're in this business. And if we're going to create a sustainable health system, we need to be really good at education and research. So that's it, one page. You know how long it took to get to one page like this? A long time.